My name is Ramin Jafari. I'm a PhD student in Biomedical Engineering Department at Cornell University, and here is a short presentation regarding the recent publication titled Rapid Automated Liver Quantitative Susceptibility Mapping in the Journal of Magnetic Resonance Imaging. Here you can see a list of authors and their affiliation. We are thankful for the funding support. Accurate measurement of the liver iron concentration, known as LIC, is needed to guide iron-chelation therapy for patients with transfusional iron overload. In this work, we investigate the feasibility of automated QSM to measure the LIC. The purpose of this work was to develop a rapid, robust, and automated liver QSM in a clinical setting. This study was prospective and included 13 healthy subjects and 22 patients. Scans were done at both 1.5 and 3T field strengths, and 3D multiecho gradient recalled echo sequence was used for this work. In clinical practice, it is desired that acquisition, reconstruction, and parameter estimation to be performed within reasonable time so the results can be added to patients' database after the scanning session. Liver QSM reconstruction in clinical practice is challenging since in addition to general QSM recon pipeline, including field estimation, background removal, and dipole kernel inversion, due to presence of fat in the abdominal area, water-fat separation is an extra necessary step. Another challenge is that QSM provides a relative measurement, and a reference with known susceptibility is required for absolute measurements in a clinical setting, and this should be automated. And finally, another question is feasibility and reproducibility of liver QSM across multiple scanners and field strengths. Here, equation 1 shows the T2 star ideal problem of water-fat separation and field estimation, which is a non-convex optimization problem of modeling the complex GRE signal capital S in terms of water content capital W, fat content capital F, susceptibility induced field F, and R2 star decay per voxel. In this equation, N refers to the number of echoes, T sub j is the jth echo time, and nu F is the fat chemical shift in a single peak model. Proper initialization of equation 1 is necessary to avoid local minimum and converges to a global minimum. 2D and 3D graph cuts algorithms are proposed to generate a correct initial guess for the field. However, these graph cuts based algorithms are computationally expensive. They sometimes have some assumptions about the field, such as smoothness or species dominant voxel. There can be problems with water-fat swapping, and finally there might be requirement for manual intervention. And this can be problematic in a clinical setting to generate automated QSM maps. In this work, we are proposing to acquire data using an echo spacing for which the water and fat are 180 degrees out of phase, which translates to echo spacing of 2.3 milliseconds at 1.5 T and 1.15 milliseconds at 3 T. Consequently, the odd echoes that have water and fat in phase with respect to the first echo are used to estimate an initial guess for the field and R2 star, which can be seen in equations 2 and 3. For absolute measurements, we chose aortic blood with 97% oxygenation level assumption for zero referencing to generate an automated mask for the aorta. Instead of typical signal intensity difference in the body, to distinguish aorta from other parts, we chose to use the geometry information to segment the aorta automatically. We know that aorta runs through the whole liver and has a circular shape. So we use Hough transform on magnitude images combined with edge information to detect candidate circles on each slice, which is shown on the movie in the left. Once we have candidate circles, then location including where the center of the circle is and its radius, and existence of the same candidate circle across all slices is used to select the final mask, which can be seen in the movie on the right. Here is the flowchart of our work for QSM reconstruction. So we had divided our echoes into all echoes and only in phase echoes. And we used in phase echo to get an estimation of field and R2 star as initial guess. For T2 star, ideal problem, which is used to calculate R2 star, water image, fat image, and field. Then the output field of the T2 star ideal, which includes both local and background field, has been used as input to the PDF algorithm, which is stands for projection onto the dipole fields to estimate a local field. Then the output of the PDF, which is local field, and here in equation 4 is denoted with F, has been used as input to this minimization problem in equation 4 known as nonlinear morphology enabled dipole inversion plus zero referencing to calculate susceptibility. Note that we calculate magnitude images from all echoes, and from magnitude images we calculate edge mask, which is used in L1 term here as mg in equation 4. And finally, from magnitude images, as discussed earlier, we calculate the aorta mask. That also is another input into nonlinear MEDI plus 0. And essentially that's the aorta mask, which is M aorta. You can see the third term in equation 4. We performed a total of 3 experiments in this study, and the first experiment was a sequence development and feasibility study in a single scanner, which was 3T, and it was done on 5 healthy subjects. The second experiment was for reproducibility analysis. It was done across 4 scanners, 2 vendors, and 2 field strengths, and a total of 8 healthy subjects were included in this experiment. And finally, in the last experiment, we performed a feasibility study in clinical practice in a single scanner, and the scans were done on 22 patients. Table 1 shows the results for experiment 1, which is the feasibility and the development method in healthy subjects. And we performed ROI analysis with the proposed IP method in proton density fat fraction, R2 star, and QSM, and compared it with the existing 3D graph cut methods known as SPURS that can be seen in this table. And here you can see the t-test and linear regression analysis shows a very good correlation between these two methods. However, the IP initializations is about 6 times shorter than the graph cuts method. Figure S2 shows magnitude, PDFF, R2 star, and QSM maps in a healthy subject across 4 scanners using the proposed in-phase method. And scanners S1, S2, and S3 are 1.5T, and scanner S4 is a 3T scanner. As you can see that there is good qualitative agreement between all scanners, except that R2 star map in S4 is higher than the rest of the scanners, and because it's known that R2 star is field stress dependent. Here table 2 shows the results of ROI measurements in proton density fat fraction, both liver and subcutaneous fat, R2 star, and QSM in all 8 healthy subjects in this study. And we performed interclass correlation coefficient between scanner pairs and also among all scanners, and you can see that there is very good correlation for all measurements here, showing that the IP method is reproducible across all scanners. Figure S3 shows susceptibility, R2 star, liver PDFF, and subcutaneous PDFF correlation and Blount-Altman analysis comparing the proposed IP method versus the existing SPURS methods. In this experiment 2 reproducibility study with 8 healthy subjects, and you can see that there's overall very good correlation among both methods. While SPURS failed in a few cases, the proposed IP method was successful in all scans. Figure 2 shows the result for the third experiment, which is clinical QSM in a patient population. And you can see magnitude, PDFF, R2 star, and QSM maps in 4 thalassemia major patients. And as you can see from left to right, liver iron increases, which can be observed in both R2 star and susceptibility maps. Table 3 shows the comparison of the proposed IP method versus the existing 3D graph cuts SPURS initialization method. And as you can see that we performed ROI analysis in PDFF, R2 star, and QSM in 19 subjects. And the t-test and the regression analysis shows a very good correlation among them, while IP is about 5.3 times faster than the existing SPURS method. In this study, we showed QSM is feasible and reproducible across different manufacturers, models, and field strengths using the proposed in-phased echo-based initialization with a 5.5-fold improvement speed compared to graph-cut initialization. It is known that QSM removes the associated blooming artifacts observed in R2 star maps and is a true measurement of magnetic susceptibility reflecting LIC. QSM also minimizes intravoxel confounding factors such as fibrosis and fat for the purpose of LIC measurement. In this study, scans failed at 2 patients due to very high iron content and fast signal decay. So QSM generation was not possible due to low SNR, and this might be addressed by using UT acquisition. In this study, we used the breath hold sequence, which was around 30 seconds. But in case for pediatric patients or the ones who cannot hold their breath for 30 seconds, then navigator with free breathing can be another option. In this work, we showed the proposed in-phase echo-based initialization method for body-fat separation is fast and robust, enabling reliable and reproducible generation of QSM maps in a clinical setting. Please refer to the published manuscript for further details, and thank you for your attention.